There's one chance to get it right, really, because it's going to take at least 5 to 10 years of people taking these medications to get an answer.
Hi, and welcome to That Cancer Conversation, the podcast that brings together the science and the stories behind cancer. I'm Sophie from Cancer Research UK. Drugs like Mounjaro and Wegovy have grown from celebrity secrets to household names. Weight loss injections seem to promise easy and effective results. But with both obesity and cancer on the rise globally, could these drugs offer more than just weight loss? And could they carry risks of their own? To unpack the science and explore what these medications might mean for cancer, I'm joined by Dr Rachel Orritt, a Health Information Manager at Cancer Research UK, who you might remember from our previous episode all about whether food can be cancerous. Rachel, welcome back to the podcast. Thank you for joining me.
It's nice to see you again.
Yeah, good to see you too. Talking about something completely different, which is these weight loss injections. What are they and how do they help us lose weight?
Yeah, so this is a group of drugs that are known as GLP-1 agonists. So it's a very complicated name for something that does something that's actually relatively simple. So they mimic a hormone that we all have in our guts called GLP-1. So often when we think about hormones, we think about the reproductive system, but actually hormones have roles across our body. And some of those roles are in the gut and our digestive system, and that includes GLP-1. So it's released after we're eating, and it leads to those sensations of us feeling full. And it does that in a number of different really interesting ways. So it has effects on organs like the stomach, so slowing the rate at which food goes through the stomach. It also has effects on the pancreas, and that helps to control blood sugar in the body. And there's effects on the brain too, so again, thinking about those feelings of fullness and also feeling fuller for longer. And so the injections with this drug contribute to those feelings of fullness and feeling fuller for longer, and that affects our appetite. So it helps people lose weight through that effect on appetite.
So we mentioned Ozempic, which is probably the most popular name that we've come across. Mounjaro, Wegovy. What's the difference between these drugs?
Yeah, so a really important point is that Ozempic in the UK isn't actually used for weight loss in the general population. It's more of a diabetes management drug. So I'll just keep my answer to Wegovy and Mounjaro, and they're brand names for two different drugs. So Wegovy is the brand name for semaglutide, and Mounjaro is the brand name for tirzepatide. And there's lots of similarities because both of these drugs are GLP-1 agonists. So they're effective for weight loss, they're weekly injections, and people might be using them for if their BMI is over a certain level and if they have weight-related conditions as well. The difference is that tirzepatide, so also known as Mounjaro, is what's called a dual agonist. So it's not just having its impact on GLP-1 receptors, it's having its impact on another receptor too. It mimics another hormone. And this is the reason that researchers have seen, or think they've seen that in head-to-head trials, tirzepatide is performing as more effective for weight loss than semaglutide. So some people ask why semaglutide at all? Well, it's because there's a few different reasons for choices of drugs. And sometimes people might have been on semaglutide before, they know that it works for them, they know the side effects are tolerable or not there, so they might default to that. Sometimes it could be that you have experienced side effects on tirzepatide and your doctor is recommending going to semaglutide as another alternative. So that's the reason there's obviously the two different drugs that are options there.
And you've mentioned side effects. What kind of side effects do we see from these GLP-1 agonist drugs?
There's a range of different possible side effects, and I think to explain side effects best, you have to bear with me while I give you a very hopefully short biology lesson, because hormones and the drugs that mimic them, like GLP-1 agonists, they're a bit like keys, and the parts of us that they act on are a bit like locks. So what we want to do is we want to open locks with those keys that lead to weight loss. That's the whole reason people are taking weight loss injections. But the problem is that a single key can often open more than one lock. So for example, if I'm taking semaglutide, I might lose weight, but I might also have other effects. So, for example, constipation or diarrhea, or for example, a feeling of nausea or sickness. And those gut side effects are relatively common with GLP-1 agonists because of the system that they're acting on. But it does vary person to person. So some people will experience more side effects than others. And what's really important in all this is to let the doctor or your GP know, because some side effects can be dangerous. And your doctors can help. So they can, for example, put you on a slightly reduced dose. That could help. It might be that they discuss a different option with you entirely, either going to a different drug or stopping GLP-1 agonists, and they can help you make that decision. So it's really important to keep them in the loop.
So we've been talking about side effects, but one where we've seen quite a few reports is around thyroid cancer, and that these drugs could increase risk of thyroid cancer. Is that true?
It's something that researchers have been looking at. It's a difficult thing to know because we don't have the length of research that we would need to answer that question for definite just yet. And often what we find is that correlations are sort of run away with, if you like, and correlation doesn't always equal causation. So the evidence as a whole isn't convincing. It doesn't suggest a definite increased risk of thyroid cancer. And in fact, there's been a recent study that included data from 48 different trials that showed no evidence of a significantly increased risk of thyroid cancer associated with weight loss drugs. So obviously at Cancer Research UK, we're keeping a very close eye as research develops, but these drugs are relatively new, so it's going to take a while to fully understand the long-term effects.
Why is it that obesity and being overweight can increase your cancer risk? What's the science behind that?
So I think sometimes when we think about fat tissue that we all have, we kind of think about it as just an extra, but it's actually quite an active part of our bodies. It's an organ in and of itself. It has effects on things like hormones and inflammatory processes and lots of other things besides. And what happens if we have more fat than our body needs is that those body processes are affected. So that in itself can impact cancer risk. Of course, it doesn't mean that somebody who is overweight or obese will definitely get cancer. That's not the case. And for someone who already has a cancer diagnosis, it's not possible to ever know for sure whether their cancer was linked to something like overweight or obesity. But one of the things that I'm particularly keen on when we're talking about weight loss drugs in particular and body weight is that we don't fall into the trap of just talking about the individual and what the individual can and can't do or should and shouldn't do. Of course, Cancer Research UK will always be there to support people who want to make healthy changes, but we need to recognise that the ability to make healthy changes is not equal across different groups. So foods that are higher in fat, salt and sugar, we know tend to be cheaper per calorie, they're more convenient, they're quicker to cook even, or easier to store. And all of those things factor into the fact that body weight is not something that is equal across the population. In fact, it's quite unequal. And the answer needs to be in looking at the root, not just treating the problem. So we need continued action from government on the food environment to help make those healthy changes a possibility for more of us.
And we've actually seen that the government are quite interested in weight loss injections being an intervention to help the growing problem at the moment. It might not be the long-term solution, but hopefully this would help. Do you think that would be the case?
It's a difficult one. At the moment, the access means that because a lot of people are accessing them privately, they are more accessed by people who have the money to be able to pay for them privately, putting it simply. So that in itself is contributing to health inequalities related to weight. And that risk that I mentioned before of if we're shifting the way we talk about weight or even keeping the way we talk about weight to what an individual can do, oh, you can take these injections, but shouldn't people be eating healthier? Shouldn't people be exercising more? And if that's the conversation, rather than, oh, hang on a minute, what's causing us to be increasingly overweight as a population as the years go by? Can we tackle some of this at the root so that people aren't becoming overweight as children, aren't becoming overweight as young adults? I think that's where the most important solutions lie. So weight loss drugs are really an interesting part of a potential solution, but they're not a silver bullet and they're not the complete solution. And we really need to make sure that we don't lose focus on prevention.
And when it comes to cancer and cancer prevention, I think some people might be listening and thinking, well, we know this reduces our weight, these weight loss drugs, and we know obesity and being overweight increases your cancer risk. Surely, 2 + 2 = 4 and this would help. But is it as simple as that?
We need the evidence to know for sure. So science has gone wrong in lots of ways in the past, and this is one of those ways. When we make assumptions that 2 + 2 = 4 in this case, we sometimes prove wrong. So what we need is evidence that lasts over a period of time. We're talking 10+ years, where we can understand that for people who've taken weight loss drugs in the past, that there's an actual direct reduced cancer effect. We don't have that yet. So that's why I'm hesitant to say, yes, 2 + 2 = 4 in this situation. We need that evidence to know for sure. And the other thing that really limits the potential of these drugs at the moment is what we've already touched on about weight regain. So if somebody is only losing weight for a period of, let's say, 2 years, and then they return to the weight that they were at before they used weight loss drugs, that may or may not have an effect on their cancer risk. It's quite a short amount of time compared to someone's lifespan to be at a healthy weight. It may still have an impact on cancer risk, but we don't know that for sure yet. So it's something that we really need more research to understand.
So you've already mentioned some really interesting questions that we still have left to really kind of answer. What are some other questions that you think is important for research when it comes to weight loss drugs?
There's so many questions left to answer. It's obviously a relatively new field, looking at GLP-1 agonists for weight loss in particular. So one of the things I'm really interested in from a cancer perspective is, what is their impact going to be on obesity-linked cancer? Are we going to see what we hope for, that these will be part of the solution for the public health issue of obesity-related cancer cases? Or is that not going to be the case? We do need more research to understand whether that will be an effect. But also kind of thinking about the here and now and people who are currently taking weight loss drugs. How do we support people to sustain weight loss and keep a healthy weight even after they've stopped taking the drugs? I think that's a really big question for us to answer, and a really important one for people who have had the benefit of these drugs but are looking for how they can keep a healthy weight in the long term. So yeah, there's lots of different questions, both on sort of a micro and a macro level, and lots of things that Cancer Research UK is going to be keeping an eye on. So definitely watch this space.
Thanks so much, Rachel, for coming on to the podcast.
No problem. Thanks for having me.
The weight loss drug industry isn't slowing down. With more clinical trials and new products on the horizon, major companies are competing to make weight loss drugs more effective and accessible. But what does this mean for researchers who are trying to keep up with answering the long list of questions we still have about these drugs? One researcher looking into the effects of weight loss drugs and cancer is Dr. Matthew Harris, a senior surgical resident and Cancer Research UK clinical research fellow. Matthew is currently working on his PhD in Professor Andrew Renahan's lab at the Manchester Cancer Research Centre Diabetes and Cancer Research Group. Matt, welcome to the podcast. Thank you so much for being here. So I'm going to start off with the big question, which is, as a doctor and a researcher in obesity, what's been your reaction of this big wave of these weight loss injections?
Well, firstly, thank you so much for having me here. In my opinion, a very, very exciting area of medicine and very exciting area of research. Obviously very biased, but there you go. So it's really been unprecedented, the uptake of these medications over the past 5 years or something like that. It's exciting because over the past 30 years, we've seen the rates of obesity rising and rising, particularly in the Western world. We've struggled in the past with management options like diet and exercise, not quite being able to be employed to curb those kind of rising rates. But we now have this new option, or many new options, as there are more and more coming each day, that seem to be really effective. They seem to be really easily tolerated, and actually, as well as treating obesity, they seem to treat quite a few other potential diseases too. So my reaction kind of at the gut level is great, but it's not quite so simple. So along with this, we have also really developed our understanding about what obesity is. Obesity as a disease over the past 10 years in particular has developed so quickly. And it's highlighted the importance of needing to treat an individual person for obesity and related diseases. So just considering, an injection or a pill as a one-shot fix isn't quite the right way to think about things. So there's lots and lots of research still to be done, but it's a really exciting time to kind of make lives better for people living with obesity.
Yeah, I'm thinking of like diabetes, and really kind of Ozempic was the start of all this. How do you start to see that move towards other diseases like cancer?
Sure. So firstly, there are around 200 complications related to obesity. So it's really complex. What we're treating our patients with alongside treating them for obesity. We have had these drugs around since sort of the early 2000s for the treatment of diabetes, first and foremost. And then after a while, there were kind of newer drugs, liraglutide and then semaglutide, so Saxenda and then Ozempic, initially used for the treatment of obesity, and then for treatment of diabetes, And then we found that patients were having quite good weight loss as well. So new trials have then assessed it for the treatment of obesity and other obesity-related diseases, and we found actually it can be really successful, especially at different doses and things like that. So then talking back around about cancer, as I suppose one of those 200 plus obesity-related complications, but an extremely important one, this is the area of our particular interest at the University of Manchester, obviously Cancer Research UK and Leeds Clinical Trials Research Unit, to see how these medications may potentially be able to interact or potentially prevent or help treat different types of cancer related to obesity.
I mean, you've mentioned that these drugs have been around, 5 years? They've been around, so not a long time to get enough of a big picture of how they could impact cancer rates.
Yeah, well, the GLP-1 class has been around for quite a while. So Saxenda for the treatment of obesity was licensed in 2014. So that's had at least 10 years of use. So we're sort of able in those timelines to be able to begin to start thinking about, these are probably safe. The newer drugs, more effective drugs for weight loss, like semaglutide or tirzepatide, Mounjaro is often called, they've been around for much less time. So we don't quite have that length of data, but certainly sort of our long-term understanding is reasonably reassuring that there aren't any worrying long-term complications from that point of view.
And with these weight loss injections, like Wegovy and Mounjaro, do you think they're a good way to lose weight and I guess help with obesity?
They've been thoroughly supported by multiple clinical trials, and, we see in our day-to-day practice that they're a great way to lose weight. But going back to a point we sort of mentioned right at the start is the importance of treating obesity in an individual basis. So it may not necessarily work the same for everyone, is the first thing. So being able to tailor your weight loss or obesity treatment approach to each individual person is really important. The second thing is we don't have a perfect understanding of how to maintain that weight loss. So with our understanding as obesity is a chronic disease, which is significantly driven by genetics as well, when we stop these medications, we've seen in clinical trials that the weight will come back on in most people. So, I think there's a fairly acceptable concept that when you treat a disease, you should treat it for good, especially if it's a chronic disease. And, if you liken that to something like high blood pressure, you would give someone a high blood pressure medication for the rest of their life, potentially. Because if you stop it, it might go back. So I think it's helpful to think about obesity in the same way. But obviously there's lots of different treatments that are very different, not just pills or injections, but also modifications, psychotherapy modifications, and even things like bariatric surgery. So we're still understanding whether these medications are for life or whether there's other strategies that we may be able to employ to keep that weight loss maintained and keep the kind of the treatment of obesity-related diseases consistent over time too.
We're seeing such a people using these weight loss injections in very different ways and maybe for different reasons, and not always necessarily to treat obesity. What's your viewpoint on that?
Yeah, so this is a big challenge, especially in the UK, especially as a doctor. So we estimate that potentially there's up to 2 million people in the UK on these medications at any one time at the moment, with 90% probably on the private sector prescription. So it's very difficult to understand who's taking it, who's getting benefits and who isn't. The other thing is how the access to private prescription and use like this can potentially fuel inequality in our healthcare system. So our most recent statistics would have suggested that between the top decile, most deprived area, and the least deprived, there's potentially a double increased chance of obesity between the two. So obviously those people who can't afford Ozempic or whatever, they may even have less access to treat that disparity, and that's going to widen over time potentially. So we have to factor that into our long-term healthcare plan too.
Well, so like, the people who are really in most need maybe of this medication can't access it.
The criteria to be prescribed on the NHS is quite stringent at the moment, and that's just because of rationing and funding. But there is already sort of a roadmap to loosen those criteria as time goes by to let more and more people access these medications. And I guess rightly, the people who have the higher levels of obesity with more obesity-related complications of even being able to access these drugs first. So that's really important.
Something that I think about is when I hear about these drugs, I'm mainly hearing about the experience on social media rather than from a study. How much are you learning from personal experiences of people taking the drugs versus maybe a clinical trial around these drugs?
No, it's a great point. Obviously, I take all of my information mostly from clinical trials, but you can't get a flavour of what's happening in the real world with that. We work very closely with a couple of amazing groups who advocate for patients or people living with obesity, the UK Coalition for People Living with Obesity and the European Coalition. So we involve them in all of our work to understand people's opinions around these medications, what's acceptable, and especially in relation to potentially thinking about future cancer prevention risk. And that's been really important to, I guess, understand how important it is for people to understand how their obesity may affect their cancer risk and how that's going to affect their decision making, especially when we're thinking about a clinical trial. So it's probably one of the most important things, having people living with obesity on board with our research, and certainly very variable. And as we mentioned, there's lots more people than perhaps we had expected taking these medications.
And with obesity and it being such a significant contributor to like increased cancer risk, what kind of stuff are you researching? And do you feel like a pressure to get these results quite quickly, seeing as so many people are already taking these injections?
Yeah. Yes. So to go sort of back to the start, I suppose, the justification for us wanting to do our work is that we, as I mentioned at the start of the podcast, there has been substantial rises in the rates of obesity over the past 30 years, and there's not really any sign of this slowing down. Obesity is directly related to at least 13 individual types of cancer, and we are predicting, even if the rates then plateau, over the next 25 years, these obesity-related cancer cases could go through the roof. So, for example, breast cancer would potentially see double the number. So this is going to be a huge pressure on healthcare systems if we don't address the long-term effects of this rise in obesity over time. So we wanted to understand how we would be able to have some evidence to inform a cancer prevention policy, obesity prevention policy that's evidence-based and is going to work long term. And we've looked at all different types of weight loss interventions. So we've talked about lifestyle, diet, exercise. We realised that on a population level, this probably wouldn't necessarily be feasible, although we think that some of our studies that there may be a slight protective effect on cancer risk from lifestyle intervention over time. The same with bariatric surgery. So there's some pretty good studies that show bariatric surgery reduce your cancer risk by about 40% over 5 to 10 years. But equally, we know that we're not going to be able to give everyone a bariatric operation, and we're struggling already to give the people that need it the most. And over the past 5 years, as we mentioned, there's been this new weapon that's almost in between these two, which is potentially scalable for a prevention strategy if we target the right groups. So we've looked at what evidence is available for GLP-1 medications to inform a cancer prevention policy. And because of the nature of it being a drug and loads of people are already taking it, real world evidence or observational data, as we call it, is difficult to really reach some firm conclusions. There's been a few fairly big studies, people, over 1 million people in America that have shown some potential long-term cancer risk reductions, but there is some difficulties extrapolating that data. And I think a lot of our discussions with policymakers is that observational evidence probably isn't strong enough to inform a strong cancer prevention policy and the implications on funding. So this is why we then have been trying to understand the feasibility of doing a clinical trial where we're comparing a GLP-1 versus something else for cancer prevention. So amongst lots of other things and having lots of international meetings and consensus and all of this kind of stuff, we have developed in silico clinical trials. So what that means is we're able to simulate what a real world clinical trial may happen, but in a computer. So we don't have to spend £50 million doing 10 different clinical trials and seeing which is the best. We can do 10 different clinical trials in the computer and see which is the most feasible. And this is input by lots of experts from all over the world. So hopefully this is something that we're looking to pursue relatively quickly.
Yeah, I mean, that must be really helpful in terms of looking at endpoints, because it's very common for these cancer studies to take a long time. And so I'm imagining this sort of thing and modelling through a computer must help with that.
Yeah, definitely. We don't have to wait an actual 10 years for an outcome. It will take 10 minutes to run in my computer, so that's pretty good. I guess the most important thing that we stay focused on is that if we do a clinical trial, there must be a firm implication. So there's no point sort of doing something for the short term and estimating what might happen in the future. If you're going to do a clinical trial that's really going to make a massive difference to cancer prevention, the outcome should be cancer at the end. So we have to really, there's one chance to get it right, really, because it's going to take at least 5 to 10 years of people taking these medications to get an answer.
Do you feel like sometimes you're having to redirect your research focus quite quickly with these sorts of drugs and how quickly they're developing and how fast, like the fact that they've gone from a injection to a pill state, does that change your design in how you're in your clinical trials?
Yeah, well, it certainly has had an effect. So you're right, it's pretty crazy, the speed of development out there. I think there's a pipeline of well over 100 medications being developed by different companies across the world. So there's lots and lots and lots and lots going on. That doesn't necessarily mean they'll all become an equivalent, but it does mean that there's several coming through. So yeah, it's a big challenge, but that's something that we're able to use our modelling and things like that to take into account.
I mean, there are so many unknowns that we still really have about the effects of these drugs. When it comes to how they help us lose weight, are these drugs going to be the way forward, or do we need to find something a bit more targeted?
It's a great question. So we know that obesity is complex, and B, the relationship to how the presence of obesity causes an individual cancer, again, is really complex. There's broadly mechanisms that would include raised hormones, raised insulin, and changes in someone's immune system. But within that, there's all sorts of different upregulation of different receptors, molecules, things going up, things going down, and they may or may not all contribute to one cancer. The pathways are all different and will be different in different people. So it's very difficult to find what we might call like an interception opportunity between one person with obesity to a future predicted obesity-related cancer. So if you're able to, I guess, treat the obesity at the start and prevent these mechanisms from happening, that can be very helpful. So that's, I guess, is the aim. We know that these medications can treat the excess body adiposity, whether it's related to your organs, whether it's in your subcutaneous space. It can do that effectively over at least the short to medium term. And we don't know whether we think that probably will prevent cancer, but we don't know it for sure. But there's something again that I wanted to talk about, is the non-adipose related or the non-weight losing effects of these medications too, which I think is really interesting. So I'm very optimistic that there will be potentially quite a considerable effect on cancer risk. The reason I say that is because there are GLP-1 receptors expressed in lots of different places, so not just in your fat cells or pancreas cells, or there's also in the brain on immune cells. And there was a recent very large clinical trial, really important, called SELECT, which is a big international clinical trial comparing semaglutide to a placebo. And they were looking at preventing cardiovascular disease. And it was successful, about a third reduction in risk. But even in the patients who didn't lose any weight, they still maintained that risk reduction. So there's clearly some direct effects on disease endpoints. And potentially this is through inflammation modulation and stuff like that, which is some of the same pathways that cancer can be caused by. So I've said a lot of times it's complex, and it is, but it's also, there's lots of potential promise as well for these interventions.
I mean, it sounds really optimistic and promising, like just hearing some of the outcomes we're already getting. Is there anything about these drugs that concerns you when thinking about somebody having to take this for the long term?
Yeah, as I've sort of mentioned at the start, they have been around for quite a while already. So we have around, a reasonable sort of 10, 15 years follow-up for this general family of drugs without any major long-term concerns. But you're right, there is cause for caution as well, of course. So there's very, very close monitoring for side effects. In fact, it's also important to be cautious that, we may not understand as much as we know about these pathways. We don't really fully understand these biological pathways between obesity, GLP-1, weight loss, cancer. And so we must be cautious about our optimism. For example, there was a clinical trial that I think the headlines were published a couple of days ago looking at GLP-1 to prevent Alzheimer's disease, and there was no difference. That was sort of a good highlight to be cautious with these things. Don't just go prescribing in. Ultimately, I guess going back to the most important thing is you treat obesity as an individual.
And something I kind of wanted to bring up as well is that recently in October we saw Italy pass their first law seeing obesity as a chronic disease. How does that start to change the perception around obesity? And, what is the significance in that?
Yeah, no, I mean, that was really exciting. It was great, and it came at a long time, a lot of hard work and advocacy over years, stretching back well into the early 2000s. The implications for Italy is that recognising obesity as a chronic disease has very significant implications on funding and management structures and things like that. So it's really has done a huge thing to remove that stigma around obesity being you just need to eat less type of issue, but much more around the complexity of the concept of obesity being disease and having these management pathways to allow people with obesity to access the right care. So that was an amazing thing for Italy, and hopefully it's sort of a real big step in the right direction to get that message out to people in general and clinicians across the world about obesity and management. And in fact, there was a study a few years ago looking at the time it takes for when somebody develops obesity to meeting their doctor to then having management, and it's at least 6 years before they'll even discuss this with a doctor. So being able to address this stigma that it's something that is treated and needs / should be treated, especially in relation to other obesity related diseases, giving people the confidence to see their doctor and not feel stigmatized or anything like that is super important.
Do you think the UK should follow suit and pass the same law in here? And how would that change things for us?
Yeah, I mean, the UK is slightly different in that there is already an obesity management pathway and plan. The NHS 10-year plan is focusing on obesity prevention and management too. So that's really promising. Saying that, there is still significant stigma around obesity and accessing management and things like that.
What are some of the next things you're looking at in the next few steps with your research, and what's exciting you about them?
We're very keen to undertake a clinical trial. There's still a fair bit of work to get that right. So as a general concept, we think probably the right thing to do would be to target people at relatively higher risks of obesity-related cancers. So they may have other obesity-related cancer precursor conditions. So, for example, something like Barrett's esophagus or something like that. So we're doing a lot of research at the moment into these sorts of populations, and we'll be working with patient organisations to understand their thoughts and opinions about how risk perception and treatment interface in those specific groups, and whether they would be interested in a clinical trial and things like that. The other thing we're very interested in is thinking about non-clinical trial ways of improving our understanding about how these medications too. So we'll hopefully be undertaking a few other studies without being able to say too much about exactly what will be happening to strengthen that non-trial related evidence base towards the link between obesity and cancer.
Matt, thank you so much for being on the podcast and sharing all your knowledge with us. And I'm very excited to see the results that come through of the stuff you've been researching.
Yeah. You're welcome. Thank you so much for having me.
Thank you. We've heard a lot of really interesting and exciting information about weight loss drugs from Dr. Rachel Orritt and Dr. Matthew Harris. But with a topic as complex as obesity, it can be hard to know what the healthiest option is. I asked Dr. Rachel what we should keep in mind as these conversations evolve. Here's what she said.
Yeah, I think for anyone who's interested in taking weight loss drugs, or maybe they're already using them, just to know that the support from your prescriber, your doctor, is so important. They should be really working with you, the two of you as a team, just as it would happen with any other medicine. So it's definitely not something that you should be sort of going at alone. Do ask for that support. And then the second thing is that weight loss drugs have a lot of promise and potential, but they're definitely not a silver bullet when it comes to the public health issue of overweight and obesity. And prevention is so key in this complex issue. So Cancer Research UK are going to be keeping a close eye on this sort of picture as it unfolds. And you'll hear more from us about this in the future.
Thanks for watching this episode of That Cancer Conversation. If you're enjoying the show, you can give us a like and don't forget to subscribe to our channel. All of this episode's resources are in the description box below. And for more cancer stories, you can visit our website, Cancer News. Also, if you have a question you'd like to ask us, you can comment below or email podcast@cancer.org.uk.